Welcoming our next speaker, Dr. Jairam Aithal. He's a consultant in interventional cardiology with over 18 years experience in interventional procedures and had pioneered treatment of complex coronary and peripheral intervention, structural heart disease in Abu Dhabi. Welcome, Doctor.
Thank you very much, and thank you to the esteemed panelists for giving me this opportunity. Thank you to the organizers of GIS. It's been a wonderful program so far, highly successful, and congratulations for that. So the previous speakers have made my task really, really easy, and they've given us wonderful lectures. My talk is basically on the use of a rota versus the IVL for heavily calcific lesions. To quickly go through what calcification in a plaque means. It's basically years of deposition that happens secondary to inflammation, followed by the release of inflammatory markers, subsequently leading to some vascular injury, cell death, finally with cell repair. If the cell repair happens in an organized manner, osteoblasts come in, play a role, and calcify the lesion. What are the factors that make people more prone to developing calcific coronary artery disease? We know most of them. People who are highly diabetic for a long period of time, excessive levels of lipids, people with chronic kidney disease, stage 4 and above, and chronic smokers. These patients are more prone to developing calcific coronary artery disease. However, the others are not exempt. Why is calcification a problem? Why is it like, Dr. Carlos said, the final frontier apart from CTOs? Now, it makes us to have difficult or prolonged procedures. Two main concerns for horrors for any consultant or an interventional cardiologist is stent malposition and stent under expansion, subsequently leading to thrombosis. What about other risks? You use all sorts of devices, all hardwares that can make us more prone to having perforations, edge dissections in the stents, failure of the procedure, and of course, the risk of contrast or X-radiation overload. Is there any known treatment for calcification? Unfortunately, no known medical therapy that would help reverse this disease. However, certain lifestyle changes can help slow the progression. Smoking cessation, weight loss, controlling of all other coronary risk factors. Of course, this has to be followed by further intervention in the form of complex PCI or a coronary bypass. What are our options with PCI? The era started with compliant balloons, went to non-compliant balloons, went to super high pressure balloons. Subsequently was the era where we had cutting and scoring balloons to try some plaque modification, fracture of the calcific fragments, subsequently followed by excimer lasers. Nowadays, pretty much we've zoned in on the last 2 or 3, which is rotational atherectomy. It's been there for a long, long time, has a learning curve, but has yielded excellent results. Of course, there is orbital atherectomy and intravascular lithotripsy, which are now the new players in the market and give us exciting newer options in treatment of complex calcific coronary artery disease. What are the challenges with these procedures? When anyone attempts treatment of calcific coronary artery disease, our main worries remain distal embolization and no reflow or slow flow. Perforations in the artery at the level of the calcification, or even distally. A lot of the times perforations you'll be seeing happens with the distal wires which are placed in some small branch. We are so busy treating the calcification that we forget or neglect the distal wire. They can happen at the level of angulated lesions. They can happen at the level of the calcium with super high pressure balloon dilatations and so on and so forth. All these are prone to dissecting these arteries. Luckily, most of these devices that we have are differential in nature, so they sort of tend to selectively target the calcium and leave the normal vessel alone. Of course, subsequently increased restenosis or neoentymal hyperplasia simply because of more inflammation, and inflammation is one of the causes for restenosis. Apart from that, there is the problem of contrast overload, the high costs that these devices come by, and sometimes in the private setup, cost becomes an issue. The most important, I think, is the learning curve. We need to train ourselves adequately before we can use these devices. The most important thing with any complex or any new device is first, do no harm. And there, the learning curve becomes tremendously important. So what does the rotablation system look like? The old rotablator had the console, had a foot pedal, had the, the advancer and the rota burr. The rota burr came in various sizes, starting from 1.25, sorry, to 2.5. And we'd use it on roughly a 0.5 to the vessel ratio. The new Rota Pro is something that can be handled with just one operator, which makes it far more easier, far more handleable, and at least the results are dependent only on in your own hands, rather than you got less people to blame. So that's the Rota Pro there. What are the advantages that a rotablator has? One, it is probably one of the few, along with the orbital atherectomy devices, that actually debulks or thins the calcium. It can be used in aorto-osteal lesions, something that not many other of the debulking devices can boast of. Severe intimal calcification can be aggressively addressed with the rotablator. Long lesions, instant restenosis, smaller vessels where the diameters do not allow for any balloon to get in. The presence of thick calcium. Now, thick calcium is something that, unless you fracture or debulk, makes it difficult to deploy stents in an appropriate manner. Nodular calcium, the first lecture was beautifully presented and discussed that the same. It also has limited use in CTOs where you partially get through the device, but no balloon or no microcatheter goes in, and you have this opportunity to use the rota burr to sort of try and make a little bit of a pathway for these balloons to get in and subsequently open these arteries, or at least attempt to open them. Of course, no device comes without its disadvantages. One of the commonest ones that most of us operators have seen is the maneuverability of the wire. It used to be a stainless steel wire, quite bulky, difficult, and most of the reasons why most of the times you'd use a rota burr is for complex lesions. Either they're heavily calcific or there's a severe angulation. The coronary artery may be non-malleable, and therefore maneuvering these wires sometimes is a little bit of a challenge. There is a definite perforation risk when you use the rotablator at higher burr speeds. Most of us have had the horrors of seeing a no reflow or a slow flow phenomenon that complicates our coronary procedures. Tortuous arteries, of course, like my colleague said, increasing the guide catheter size sometimes can have issues. Many of these patients have, would like a radial procedure. Getting a 7 French or an 8 French catheter through the radial artery is not the most comfortable of businesses to attempt. Then deep calcium. Deep calcium is something that the rota burr cannot really address, and that's where the IVL scores over the rota burr. And of course, the presence of eccentric calcium. So if there is a wire bias against the area of the calcium and towards the normal tissue, it renders the rota burr less effective. The optimization of rotablation was already spoken about. You use a 0.5 burr ratio, go at low to moderate RPMs, and use a pecking motion for small periods of time. And that's how it normally looks. So you look at the calcification, pretty obvious, and after rota burr, it facilitates angioplasty and stenting. The intravascular lithotripsy, on the other hand, basically uses shock waves. It converts electrical energy into mechanical energy by vaporizing the mixture of saline and contrast, and develops short pulse bursts of up to 50 atmospheres from inside the artery, thereby helping fracture the calcific, the circumferential calcium inside, and the advantage also being that it can go to the deeper calcium. What are the advantages? You use the same 014 wire, so you can continue your angioplasty over this wire. It has a smaller learning curve because it's pretty much doing a modified angioplasty. There is no risk of distal embolization because it only helps to fracture the plaque and not really debulk it. You can protect the side branch with another wire, which you cannot do with a rotablator. You can't put a side branch wire. Certainly less dissection risk. It can fracture the deep calcium, thereby rendering the plaque more compliant. Circumferential plaque modification is possible because of even pressure dispersion as against most of the balloons, and it can be used inside under expanded stents to break the calcium behind and therefore improve stent expansion. Disadvantages? Well, uncrossable lesions, severe proximal angulations. It is a bulky balloon. It has a learning curve. It's a small balloon, so you'd have to use it for a longer period of time, increasing X radiation if there is a long lesion. And certainly for CTOs, you can't put a balloon of that size. So this is an example where in the figure E, you can see the fracture in the calcium following use of an IVL, and therefore helping in the placement of the stent. Now, if you had to actually compare rotablator with IVL, the guide wire size, the advantage goes to IVL, where they use the standard guide wire that you can use for most of your angioplasty. There is definitely a wire bias with rotablators, which is not present with an IVL simply because it evenly disperses pressure. The risk of perforation, distal embolization, bradyarrhythmias all remain with rotablators, thereby maybe necessitating the use of intracoronary medications as well as a temporary wire. Deep calcium can be better treated with an IVL. It can break both superficial as well as deep calcium. So if one had to choose for balloon uncrossable lesions, for diffusely calcified long lesions, certainly one would look at a rotablator, also to debulk lesions. But for deep calcium and circumferential calcium, I think it's important to use an IVL. So what would determine success of these procedures? You prepare the hardware, prepare your lesion, prepare for complications. Be ready to react to any situation and maintain a skill set and constantly update your learning experience with these. Just a quick note on calcium, because all this is about calcium. While angiography is a poor determinant of calcium, this is what most of us have in our armamentarium. OCT and IVUS certainly would help with the length, distribution, depth and thickness, and with classifications would help you determine first choice of treatment. So in an angiogram, as you can see in figure B1, you can see that during motion, without the injection of contrast, you would be able to see calcific deposits, whereas severe calcium, you'd be able to see a tram track-like appearance. This is C1, and the calcium would be seen despite you injecting the artery with contrast. So that's the IVUS. It's been discussed before. I'll quickly go through this algorithm that we would normally prefer to use for such patients. People with mild calcification, you'd go with balloon predilatation, followed by, if there is suboptimal result, you'd either go with an IVL if it is crossable, otherwise can I take just 1 minute more, please?
1 minute, please.
This is the last slide.
Just to show the
algorithm, yes. And we'd use lithotripsy if the balloon crosses, otherwise you'd use a rotablator, but for moderate to severe calcification or uncrossable lesions, you'd use the guide of the point system. If there was a large arc more than 270 degrees, if the calcium length was more than 5 millimeters, thickness was more than 500 microns, certainly you'd want to look at lithotripsy. If it doesn't cross, use the rotablator. There is the concept of rotatripsy, where you could use both together to try and optimally provide results and get the best minimal lumen area possible. I stop here. Thank you.
Thank you. Thanks. Yeah, so do we have any comments from the panel? Or?
Yeah, if I can,
Omar.
I think the black, we may divide the black to two categories. Heavily calcified plaque, which can be the circumference or the thickness, and heavily calcified plaque with a critical stenosis. Because sometimes you have heavily calcified artery, but not necessarily severe stenosis. I think when you have a critical stenosis, probably rotablator is the way to go. But when you have not necessarily critical stenosis, especially for heavily calcified, as you said, the deep or circumference, probably that's what I find in my practice. It's lithotripsy may be more effective, because there's difference between enlarging the lumen or making the plaque more compliant with the balloon. So I think it's most of the time we need to get the plaque more compliant with the balloon, and that probably lithotripsy do better job than unless the patient, unless the stenosis is critical.
Absolutely, sir. So where IVUS or OCT is available, this becomes easier, but where it's not, like in many cath labs, you just go by angiographic definition. With that, you'd certainly start with a balloon, and therefore I think most of these algorithms start with crossability with a balloon. If it's balloon crossable, then using an IVL becomes an option. If it's balloon non-crossable, I think you're left with no choice but to start with a rotablator.
Second thing, I found it very, very helpful, actually. Recently, I'm doing more and more of CT angio as pre the angiogram. It makes you so much have informed planning before. It gives you the thickness of the calcium, the circumference of the calcium, the location, the degree. So I found it very effective, actually, very helpful. before the diagnostic angiogram to do the CT angio. Matter of fact, the CT angio, I'm doing it now as a first option to evaluate the chest pain, of course, the borderline, instead of having the stress test as a first option, because I found it more helpful to make the plan.
I think we have, as a group here, to have to reach the audience in practice. Are you doing the algorithm or not? Because there are a lot of algorithms since 2014, 2016, and recently by Carlo De Maria. I think Carlo De Maria with us had the publication in JACC about the last algorithm, uncrossable versus crossable lesion. If there is uncrossable, this is not the ballooning. This is rota or orbital atherectomy. So in core lab, you have a rota. If you are experienced in orbital, okay. Then if it is a crossable, you go for the type of the calcium. Is it superficial, deep, or nodular? If nodular, it's not shockwave, so avoid. Then superficial and deep. If you have a superficial calcium, you go for only ballooning. Whatever the balloon, non-crossable, non-compliant, or balloon, whatever you have done. Then the deep, the question. Is it to use an OCT or IVUS to determine the scoring, and you go for the IVL or this? It is depending upon your experience. I need the experience, Andrea. You're using routinely OCT and IVUS for identification of the type of calcium in order to reach either shockwave or rota or.
I wouldn't say routinely. This largely depends on the operators in our center. And we also have to look at the economics, right? So if it's a very calcified lesion and it's circular, and I just get a balloon in, I'll use lithotripsy or the rotablator, depending on what it looks like and how the approach is. But I wouldn't say I always 100% use imaging to identify calcification. You can identify calcification simply by not being able to inflate a balloon, right?
Okay. Thank you for the lecture.
Thank you very much again.
طيب.